the way we can wean patients off parenteral nutrition. Can you see my slides now?
Yes, sir.
Perfect. So my objectives today are to talk about how teduglutide works. We'll talk about who are the patients who benefit the most from this therapy. And I will show you the way we're trying to taper the parental support with teduglutide, which is the brand name Gattex. So to start with the background, I don't have lots of slides to show you overall and regarding the anatomy of patients with short bowel syndrome. But by definition, if we talk about short bowel syndrome, these are the patients who have less than 200 centimeters of small bowel. So that's the definition. If you lose more than 75% of your small bowel, then we essentially having patients who have some issues related to nutrition, and many of them will require long-term parenteral nutrition. So we know that short bowel syndrome is a challenging condition to treat, and it's also challenging in a sense, very complex condition, and has major impact on quality of life. And we know that short bowel syndrome patients have issues with diarrhea. They depend on parenteral nutrition. So, doing the night cyclic TPN creates some problems. Traveling is an issue for those who require parenteral support. So in general, historically, the management of short bowel syndrome was based on support with parenteral nutrition. And as you've heard already, parenteral nutrition has also has some long-term complications. And the most common overall are related to infection, sepsis, some related to the central access, especially thrombosis. And finally, we talk about even end-stage liver disease. So in regards of goals of management in short bowel, the key is to obviously prevent dehydration, reduce diarrhea. We're trying to correct nutritional deficiencies. We're trying to maximize intestinal absorption by providing you with anti-diarrhea medications, trying to stabilize the weight. But when we look at the end point, we're trying to improve your quality of life, and we're trying to restore enteral autonomy, which means eliminate need for parenteral support and IV hydration. So I think from our standpoint, the success, that's what we expect to see. So traditionally, when we look at the patients and we talk to our patients with short bowel and dependent on parenteral support, we're trying to determine overall, find the risk factors that will require long-term parenteral support. And traditionally, we believe that patients with small bowel length less than 100 centimeters and end stoma, or those with very short bowel, 65 centimeters, and colon, unlikely will get off parenteral support, and they'll be dependent for life. Similarly, we thought that those who are on TPN for more than 2 years, they'll also be in trouble. So what happened, we overall got this new medication, teduglutide, and we believe that can change how we approach patients, and we hope we can prevent overall intestinal transplantation for some of those patients with short gut. So I wanted to bring this slide, which is critical because that's what teduglutide was developed on. It was based on glucagon-like peptide, which is hormone produced in the GI tract, along the GI tract, and those patients who have bowel resection, they're unable to produce glucagon-like peptide. And this slide showing you that in animal study that there is significant increase in the mucosa of the small bowel with the GLP-2. So what is teduglutide? What is Gattex? It is overall recombinant analog of this hormone glucagon-like peptide. There is a substitution in one of the amino acids allowing that this drug is more long-acting, stays longer in the system and has more profound effect. Now, teduglutide was approved by FDA in December of 2012. So we have almost 9 years of clinical experience. And we don't know exactly how many patients at this time we have in the United States on teduglutide. But definitely in comparison to other parts of the world, the highest number of patients on teduglutide is overall in the United States. So if you look at the mechanisms of action of glucagon-like peptide and similarly teduglutide, it has multi-directional effect. So in comparison to other drugs, you can see that the list is quite long. But the key is that has effect on small bowel lining and increases so-called villi. So you can increase the surface of absorption. So as an example, you may go from the field of basketball to field of football field, and you can see that there will be significant increase in absorption. Well, that allows you to increase more fluids, increase more nutrients. On the other hand, also has effect on bowel transit. Now, what are the indications for teduglutide? So initially, the drug was approved mainly for adults, and in the last few years for children, age 1 and above. Now, you have to meet those criteria for the drug. So the patient should have short bowel syndrome, the age range, and finally has to be dependent on parenteral support. And we talk about parenteral support, we mean TPN or IV hydration. It could be even IV magnesium infusions. So I wanted to show you a few slides on how the drug got approved. And this is overall the first clinical study, we call this phase 3, how the drug got approved. So the experts got together and trying to find out how we can determine that the drug is effective. So they look at the 20% parental support volume reduction weekly. If we can reduce more than 20% of parental support per week, this is clinically significant. So you can see on this slide, there was a patients in green, I'm sorry. In green, you can see that patients who received the teduglutide, they have 63% of them achieve this endpoint of significant reduction in comparison to placebo, 30%. The second outcome was to look at how much volume we can reduce with the drug. And this is still the same study. And what this slide showing you, again in green, that at the end of the study, 24 weeks, the mean reduction was 4.4 liters so per week. So you can imagine if someone is receiving 10 liters per week in 5 days, you can almost reduce 2 to 2.5 days of parental support. The other point from this slide is that you can also see how quickly there was a difference between placebo and patients who received the therapy. And it overall took 8 weeks. So if you look for how quickly you can see some difference in response and reduction, it took on average 8 weeks at least. The third point to make is to look at the days of parental support. And again, in this particular study, you can see that patients who received Gattex, 54% of them had 1 or more day of reduction in parental support in comparison to placebo. Now, this is important slide because there are few overall phase 3 studies, and they put all these patients together. And as I show you, there was a reduction in parental support requirement, but not as many patients overall got completely off parental support. Only 16 patients from 134 patients. So only 12% of patients achieve complete tapering of parental support. So they achieved the enteral autonomy. Now, what are the predictive factors? Who were the patients who did well? And here are the patients at the bottom of the slide. Patients who had colon incontinuity, so they have colon in place, 12 of those patients, and those who have lower requirement of parental support. So if you require less fluids, higher chance that you'll get off parental support. Now, the other point to make that also patients who require very high volume, they overall have the highest reduction, percentage of reduction of the volume reduction. Now, if we look at the clinical data, and this is a study from New York with 18 patients, and we are talking about just clinical practice, not research, we have much better results. You can see here in this particular study that 61% of patients were completely weaned off of parental support. In comparison to only 12% in initial research studies. Now, again, what we find from this study, 90% of these patients had colon incontinuity, and it took on average 10 months to get off completely of parental support. But in some patients, up to 3 years, 36 months. So it takes extra time. So how we use Gattex? What is the dosage and administration? So the dose, there's one dose for adults, 0.05 milligram per kilogram daily. For pediatric population overall, they use dose, it could be half of this dose, and the drug is given subcutaneously as a subcutaneous injection. So the drug can be injected in an abdominal wall, thighs, arms, and we do reduction in a dose in patients with advanced renal disease. So if they have severe renal impairment, we cut the dose by half. And the good news is the drug can be stored in a room temperature, so it doesn't have to be in a refrigerator. Now, this is overall a slide showing you how you have to mix the drug. And this is a little bit cumbersome, obviously, just even looking at this slide, it's like a chemistry or physics class, but you have a couple syringes, you have to mix and, pull the drug out of the vial. So it is a little bit cumbersome. So I think we need different form of delivery of the drug. So we have to talk a little bit about the side effects and safety issues. And overall, I suspect you may have some questions regarding the cancer risk. So we have understanding that theoretically, there is a risk of growth of the colon polyp. And if the colon polyps grow, maybe even higher risk of colon cancer. But we don't have any data overall. There's no single case of cancer so far. Now, we know the drug only works on a GI tissue or tract, so there's no effects on any other organs to our knowledge. Because of the issue with the risk of polyp growth, it's recommended to get colonoscopy just before starting Gattex therapy and then at 1 year of therapy to see if there are any polyps, and then you go back to routine surveillance if you have colon incontinuity. Now, if patient is diagnosed with intestinal malignancy, gastric cancer, colon cancer, pancreatic, then the drug should be discontinued. For patients with other cancers, overall, it's a kind of discussion with the oncologist if the drug can be used or continued. Now, the other interesting issue is risk of intestinal obstruction. In a research, there are more than 10% cases of intestinal obstruction. And that can be related to the effect of the drug on GI tract motility. So if patient has mechanical obstruction, there is evidence of stricture, the drug may be discontinued temporarily until surgery is performed. Let's look at other issues. Interesting problem can occur. It's fluid overload. If parental support is not properly adjusted, in some patients, because of increased fluid absorption, you can have excessive fluid retention and overload, and especially in patients with cardiac disease, there is a risk of so-called cardiac decompensation and congestive heart failure. So overall, we discussed this with the patients, be aware of any respiratory issues. This is the time that we have to rather quickly reduce the volume of parental support rather than stopping the therapy with Gattex. Other adverse effects, very common, is stomach swelling. You'll find this in almost 40% of patients, and that applies to those who have stomas. It could be angiogynostomy, ileostomy, or even colostomy. This is normal effect. What's happening is the just growth of the lining. The other point to make, the drug also affects other medications. You may expect improved absorption, other medications, so they may be more effective. So there may be need for drug adjustment, especially anticoagulation. For example, if you're on Coumadin, the drug will be more effective, so the dose has to be reduced. Anti-anxiety medications may need to be adjusted, or pain medications. In studies also, there's reported up to 20% injection site reactions, but these are minor. Now, the stoma enlargement, what we do with it, typically we do nothing. We'll leave the stoma alone. It should be fine. It rarely hurts. It may increase a couple times in size. So when we started initially the therapy, some patients were very concerned going even to emergency center for reevaluation. Occasionally, you could reduce the dose of Gattex and the stomach get a little bit smaller. It really affects the appliances, but if there's any issue with the appliance, you may involve the stoma nurse consult. Let me see if I can move this bar. Okay. So the other adverse effect, which is quite common, it's abdominal pain and bloating. And I wanted to mention here because in the studies was seen up to 37% of patients. The abdominal pain and bloating can be related to change in motility, effect of the drug, possibly some effects of the pain medications because they're becoming more effective. And there's a so-called narcotic bowel as well. So I mentioned here different options. The key is not to stop the deglutide, rather continue, but use different approaches, including anti-gas medications, antispasmodics, possibly probiotics, antibiotics. Some patients may be at risk for bacterial overgrowth. Occasionally, you can reduce the dose of Gattex by 50%. It may be reasonable. And finally, if patient is on pain medications, you may look into it if these pain medications are just too powerful, may contribute to the symptom. So we have to set up the goals, and what, the patient expectations are important when you think about weaning process with Gattex. So the right goals are very important in this setting. So, we have to discuss with the patient what you can expect. You can expect volume reduction. So you may see shorter cycles or maybe less days of parental support. Every patient is different and depends on anatomy. There's several factors. So not everyone can get completely off of parental support. Now, the other issue is that do not expect that you will get very quickly off parental support. It's not going to happen overnight. So you need some time. So it's important to set up those goals. Now, as we said about weaning of parental nutrition, there are several factors that essentially as a patient, really you don't have any control over it. We know that patients with shorter bowel, which I mentioned earlier, very short segment of small bowel and end stomas, they have lower chance overall getting off parental support. If you have colon incontinuity, you probably will do better. If you have ileocecal valve, which is so rare overall, preserved ileocecal valve, these patients do better. There's some bowel adaptation takes place, and also not always we have control over that. And your underlying disease will also have effect, regarding weaning. If you have underlying disease, Crohn's disease, possibly radiation, not healthy small bowel, the remnant bowel, it may be more challenging. Now, on the other hand, the only thing you can have impact, it's overall improve and be compliant with the medical therapies and diet, and really use those oral rehydration solutions, which Carol was talking about. All these small steps can help you and you have probably better chance of weaning of parental support. So the compliance with those critical steps is very important. So what we expect from you as a patient, we wanted you to be definitely adherent to parental support, being sure that you get the right volume every night, that you are complying with the diet, fluid intake, oral rehydration solutions. You take all the additional medications to control diarrhea, and you have to be compliant with Gotex injections. You cannot skip them. Obviously, otherwise, you may not have such a good results. Now, we're also talking about education and self-monitoring, and there are some steps that you have to follow. And that includes, monitoring your urine output, looking at stool output, and you have to follow recommended visits, follow-up visits, do colonoscopy, follow the blood tests. So one point to make is that it's important to have multidisciplinary team, and that can guide you through the whole process of weaning. So, you need the leading physician who will kind of coordinate. You don't have to have everyone on the team, but in general, it's good to have dietitian, pharmacist, stoma nurse, and social worker that work as a team, and the communication is critical overall. Now, one thing I wanted to mention that since the Gotex got approved, there was a program developed called One Path, and this is kind of to coordinate your care. And this overall, the program is not only for patients, but also for the physicians, healthcare providers. So this program allows you, you'll have assigned core care coordinator who overall takes care of lots of issues regarding insurance authorization, appeals. They help you with the questions regarding Gotex, local resources, connections, and copays. So this is very important program, very helpful for patients. So let's talk a little bit about the weaning of parental support with Gotex. And when we look at it, it's multi-step process. And first is education. You have to be well educated about all these steps. Be sure that you know how to keep track of daily intake, urinary output, stool characteristics. Then we go through the step called optimization, when we wanted to be sure that you have proper hydration and nutrition status, that your drugs are well established, the dosages, that you follow the diet and really maintain good hydration with oral hydration solutions. So how we get to this optimization, we wanted to be sure that your urine output is at least 1 liter per day. So you have to measure your urine. You don't have to collect your urine, but you should measure how much urine you produce a day, because if it's less than 1 liter, we probably wouldn't start the tapering because there is high risk of dehydration. So we have to recognize, we measure BU and creatinine. So this is marker of dehydration. And you have to recognize signs of dehydration, and you shouldn't have any symptoms, thirst, fatigue, because these could be signs, as you heard earlier, of dehydration. And then we wanted to be sure that you have adequate nutrition. Sorry for that. I think I have a slides set up for some automatic switching. So you have to have adequate nutrition. You should get enough energy, and you should have stable electrolytes, prealbumin. Overall, in regards of adequate nutrition, we have more difficulty determining this because we don't have any markers. We are much better with figure out about hydration status. So when we start weaning, obviously everything is about monitoring, and we do adjustments. We cut the volume and frequency, and we talk more about that. And we keep eye on your hydration status by measuring your urine output. We look at the nutritional status, so we monitor your electrolytes, mineral, vitamin levels, and we have to adjust medications, as I mentioned. As you go through the process, you may have much better absorption of the medication, so they need to be adjusted. And if you get off parental support, it's the same concept that we don't stop monitoring. I mean, you have to be under close supervision, and we have to have those follow-ups arranged, because we still have to continue to monitor your vitamin levels, nutritional status, hydration. So it's a long-term process, even if we get you off parental support. So what are the options of parental support reduction? First of all, we can reduce your daily volume by 20-30% per day. So you'll be on shorter cycle. The other option is going by just percentage of weekly volume. That's also other option, but that essentially means we reduce number of days on parental support. So we may go from days 5 to 4, and then we cut by 1 day. And the final option is on some patients, which we overall done on few, then when you get better and you reduce parental nutrition requirement, you can just go switch to IV hydration only. And I have a patient even right now that we are able to change to IV hydration since she was able to manage her weight. So that's another option eventually. This is not at the beginning switching straight from PN to IV hydration, but in a long process can be achieved. So this is how we're trying to approach patients and how we reduce parenteral support. So we rely on weekly monitoring of your hydration status and nutritional status, but we always worry more about hydration, because if you get dehydrated, patients will feel much quicker. The dehydration affects you and can shut down your kidneys. So if there is a problem and you don't produce enough urine, less than 1 liter per day, probably you have to stop the reduction and monitoring, trying to make some adjustments. Similarly with nutrition, if there is a problem, you're losing weight with reductions, we have to maybe stop and maybe even go back. But if you're doing well, our plan is to reduce the support by 10 to 30% every few weeks. It's not going to happen weekly, but we have to just pay attention and follow you very closely and make those adjustments. And again, it's mainly based on hydration status and partially on nutritional status. So for those patients who get off parental support on GATTEX therapy, how we manage them, we look at looking for dehydration, looking at BUN creatinine ratio. We checking the weight, we check intermittently urine output, and we wanted to be sure that you are compliant. That you are compliant with medications, compliant with diet and oral rehydration solution, and you have to be compliant with vitamin and mineral supplements. There are a few papers showing that overall your vitamin and mineral supplements may be much higher if you get off parental support. Now, you may ask me how often we would monitor your electrolytes, micronutrients, vitamin levels. And obviously at the beginning, if we get you off parental support, we'll probably be monitoring more frequently every few weeks, then every 3 months, and eventually every 6 months. So depends on your mineral, electrolyte and vitamin, trace mineral levels, those decisions will be made. Now, if the numbers go in the wrong direction, we obviously will restart your parental support. And that may happen, for example, in the summer when patients get badly dehydrated, they may need short-term hydration, or if patients are hospitalized, you may need to go back to parental support temporary. So the next issue is, who shouldn't be on GATTEX? Are there any contraindications or patients who probably won't get better on GATTEX? And the first group, as I mentioned earlier, because of the risk of cancer, patients with GI cancer within 5 years should not be on GATTEX. And there are some patients also with certain type of polyps or risk of colon cancer. For example, FAP, patients with colectomy and high risk for duodenal tubulovilous adenomas, these patients can progress to cancer of the duodenum. I don't think I would use this drug. On the other hand, patients with dysmotility who have normal length of the bowel they're not candidates. I mean, the drug is not to help with this motility, increase absorption, but also affects motility, slows down. So this is not the group of patients that the drug should be prescribed at all. And the third group, which is relative contraindication, patients with strictures or some obstructive symptoms. But again, if the obstruction can be fixed surgically or bypassed, treated appropriately, a Crohn's disease with biologics, there is not, complete, full contraindication to use the drug. So I would still be using it. So shortly about obstacles to the therapy. A few years ago, I know the drug is on the market for almost 9 years, but there are patients still kind of trying to figure out if this is the right drug for them. And the patients have own vision if they feel that the drug is the right one for them. Obviously, there was lots of concern about risk of cancer, neoplasia. However, so far we have no cases of cancer. We have cases of colon polyps. They may appear, but with proper surveillance, we can remove them. So I think we are fine. Now, one of the major issues is this daily injections. And obviously we can say, this is a little bit cumbersome and we are looking for better solutions. So some patients trying to overall use the drug every other day. Other issue is the side effects. As I mentioned, abdominal pain, bloat. For some reason, especially unexperienced physicians may stop the drug too early. So if you had those symptoms, I would probably encourage going back, and sometimes these symptoms resolve with a little bit longer therapy or by using the medications I mentioned. The insurance problems are rather rare. If you're on parental support, there's probably no problem to get the drug approved eventually. You may need some support program, but that's rather rare. And I always say one of the obstacles, especially for a few years, was that many doctors have no experience. So they're not willing even discussing this issue with the patient. They're not familiar with the drug. And there's some concern about the cost of the drug because it's very expensive therapy. The effects that not everyone gets completely off parental support. So there's some doctors who are not believers in a Gattex therapy. So what are the unanswered questions regarding this therapy? And I'm sure probably you may have them written down already. So first one, how about the duration of therapy? If you get on Gattex, how long you're going to be on a drug? And I would say you have to stay on it long term. If you stop the drug, you get back to square one. You'll be back where you started. You will require TPN or IV hydration. And that has been shown in some studies. Those patients who get off the research trials, many of them, after the drug was stopped, they have to go back to the therapy. Now, can the injections be given every other day? I would say yes, in some patients stable after a while. At this point, since we don't have other option, maybe every other day injections are fine. Now, the one issue is also when to start Gattex therapy in relation to the onset of short bowel syndrome, when patients have massive resection. And we typically don't recommend to start very early. And the reason for it is that also patients are very unstable. The requirements for electrolytes, TPN changing rapidly, especially their big fluid shifts. Patients get readmitted to hospital. So initial therapy, it's a little bit challenging. There's also natural intestinal adaptation taking place, which may take up to 2 years. So we don't know exactly, but most initial research was done in patients who were at least 1 year from the surgery. So that's why lots of insurance companies wanted to be sure that patient is probably 1 year from the last surgical resection before they approve the drug. In regards of optimal patient selection, as I mentioned, I think the patients who really do well, those who have colon incontinuity, but on other hand, and those who require low volume, these are the patients who will get off parenteral support. Now, those who have high parenteral support volume requirements, they also benefit, and they have probably the highest volume reduction. So they can have few days reduction of parental support. They may not be able to get off completely of parental support. Now, the one issue we have, and I don't think there's an easy predictor who's not responding, because as I show you, it takes several months to get you off parental support, get the final intestinal, autonomy. So the issue is that, how long you are going to wait. I mean, if you don't see really any drop in reduction of parental support, that's obviously probably it's time to stop it. But nobody knows overall regarding the initial duration. Now, obviously, because if you have side effects, you can stop the therapy. Now, the other issue is long-term safety and efficacy. The main issue is, I think for adults, so far, we don't have any data. Again, risk of cancer is rather low, despite of this precaution. In children, when you start at age 1 and be on a drug for whole life, I think we need more long-term data. So what's on the horizon? I wanted to just shortly show you a few drugs. And these are, again, drugs that have been developed, and 2 of them, and they're mainly related to this GLP-2, glucagon-like peptide 2. So the whole concept is to develop long-acting drugs. So you can see here underlined, they will be given once a week. And there are 2 drugs right now in a phase 3. So they're tested in the United States as a weekly injections. Now, this drug, glepaglutide, is also developed as an auto-injector. So it may be also different delivery, which may be beneficial. Then there's one company from Boston, Entera Bio, who is trying to develop oral GLP-2. That will be very interesting because we don't know about the absorption. Again, depends on the length of the bowel. So that will be very interesting, but this is really in early stage, I believe. And we are looking also that probably Takeda will come up maybe with weekly injection drug, the teduglutide, but I'm not sure what stage they are right now. But I think because of competition, I think they will be trying to do something different as well. And another drug related to different group, GLP-1, glucagon-like peptide 1, which also has been shown to be beneficial in short bowel patients, has been currently tested as a biweekly injection. So we have to see what's going to happen with this drug. This one is only in phase 2. So from this group of drugs, I think apraglutide is the closest will come to the market. It's the end of the study, probably 2023. So maybe in 1 year, we'll see this drug coming to the market. So shortly about the case I wanted to present. This is overall real case. One of my patients, he was very unfortunate, 71-year-old gentleman who had complications of simple surgery, sigmoid colectomy for diverticulitis. And somehow he developed serious complication, I believe, just ischemic bowel, and lost majority of the small bowel. He was left with 90 centimeters of small bowel connected to transverse colon, very unusual anatomy overall, 40 centimeters. And he had the transverse colon pulled to the skin, so he had end colostomy. So this patient, when he came to me, he was on PN dependent for 1 year. He was receiving 1.6 liters of fluids 6 times a week. And he also had problem with high stoma output, which was one of the major concerns for him. So we started him on teduglutide. And in the first month, I just wanted to see, show you his bumpy road. So he developed abdominal pain and severe bloating. Overall, this is really severe bloating. It was very unusual. He had very loud bowel sounds, and I felt that he maybe had bacterial overgrowth, which is common in patients with colon incontinuity. And overall, I treated him with several antibiotics, and I think that was going for at least 2 months, maybe 3 months, but we gave him doxycycline for very prolonged course, 3 weeks, and overall his symptoms completely resolved. Now, in the first month of the therapy, he also had stoma enlargement. So colostomy got enlarged, was managed conservatively. Then in the first and third month, he reported to me that he had episodes of small bowel obstruction. He had nausea, vomiting. On one of the admissions, he required NG tube. And we start evaluating why he has a problem. And we found site of mechanical obstruction, which was kinking of his bowel at the stoma site. So he had surgery by colorectal surgeon, and we temporarily stopped teduglutide, discontinued. And then after surgery, he went back on the drug. Now at month 16, he developed fluid overload and congestive heart failure. He was seen by cardiologist. Now at the same time, he was found to have renal insufficiency. And we have the problem that because of his worse kidney function, I guess he got to this fluid overload. So obviously we taper his fluids first. We cut down significantly on fluids while keeping him on teduglutide. And then we performed colonoscopies on him, which were normal. We never found any polyps, but he had only very short colon. And on month 18, I scoped him, and he had overall prior endoscopy. He had GI bleeding, and we found this large duodenal polyp, enormous polyp, which we resected, was benign. And we overall written this as a case report, as a first case of polyps growing in the duodenum, not in the colon. And as you can see, on month 18, he was completely weaned off of parental support, and he stayed on Gattex therapy for more than 40 months. And I overall lost him because I moved to another center. So I wanted to show you how bumpy road can be, but it's something that we work on. And you can see me to the left here. What we're trying to do, what is impossible, we're trying to switch, do things possible, and that's how we're working hard on our patients. If the patient is in the right center, you have right physician, we can work very hard trying to reduce your parental support, and we hope we can get you completely off. So in conclusion, what I wanted to show you that the Gattex is very unique. We call this targeted therapy because it works on the gut. It increases the size of the gut, the villi, increases the absorptive capacity of the gut, and gives you the meaningful benefits. We can partially wean off parental support. We can, in probably more than 20%, maybe more, completely discontinue parental support. It appears to be safe and well tolerated. The weaning process, definitely it's complex, but can be achieved if you have the right team. And if we completely get you off parental support, definitely we need to continue to monitor, and you have to be well educated and pay attention, and be compliant with mineral vitamin supplements. And I'll stop here and I show you my final slide, which I like. It's telling you that, the doctor telling the patient, this is one of those new miracle drugs. If you can afford it, it is a miracle. And I stop here. Thank you very much for your attention.